Good morning, everyone. Welcome to the Cleveland Clinic Endocrinology and Metabolism EMI Live Grand Rounds. I am Vinni Makin, and today we are going to be talking about lipids. EMI Live is initiated from our department chair to bring out our educational initiatives to community endocrinologists as well. You can also check out our YouTube channel for previous presentations, and this presentation will show up there as well. We are very glad we have Dr. Leanne with us today, who's going to be talking about a lipid guideline update. And along with that, we're going to start with a very interesting case from our first year fellow, Dr. Michelle Lundholm, who's going to be talking about a case of hypertriglyceridemia. Dr. Lundholm, the stage is all yours.
Thank you very much, Dr. Makin. So welcome all to our EMI live case discussion. As Dr. Makin mentioned, I'm Michelle and I'm a first year endocrine fellow. I'll be taking us through a case today titled The Challenge of Hypertriglyceridemia. Can everybody hear me okay? Okay, yep. Great. So this is a 24-year-old female who presents to the outpatient endocrine clinic with Dr. Morey-Vargas in April of this year for management of high cholesterol as well as diabetes. So she has mixed dyslipidemia with severe hypertriglyceridemia, which was diagnosed by an outside physician around the age of 10. So this was diagnosed back in 2007. At the time, her triglycerides were over 1,000. This has been complicated by recurrent pancreatitis, and she has had 7 hospitalizations by this point in time, and I'll discuss these more in a moment. Her lipids are currently being managed on fenofibrates, Lovaza, and rosuvastatin. She has an unstructured diet with skipped meals and lots of snacking. She also has a history of obesity and type 2 diabetes. She has obesity class 3 with a BMI of 40.7, and her A1C is 7.9%. She's currently on insulin, which was started 6 months ago. Previously, she had been on orals. And she is on this regimen with glargine and Lispro. As for her diabetes, it's complicated by albuminuria. Here's a brief timeline of her hospitalizations for pancreatitis and how this has been managed to this point. I know we have some of our internal medicine colleagues with us today, so this is a good example of the many etiologies of pancreatitis. So recall she was diagnosed with hypertriglyceridemia in 2007. Her first hospitalization was 10 years later. She had just turned 21 and celebrated her birthday with a night of drinking, which is otherwise uncharacteristic of her. Unfortunately, she developed pain the very next day and was admitted for the first time with pancreatitis. She did have high triglycerides, but given the story and being on a fibrate, the alcohol and the fibrates were thought to be the etiology. She has since been abstinent of alcohol. A year later, at age 22, she had her second admission. This time it was more serious. She developed necrotizing pancreatitis and had a pleural effusion and oliguria requiring dialysis. By BISAP and Ranson criteria, this is someone with a very increased risk of mortality of 15 to 20%, and she was in the ICU. Fortunately, she did recover. However, a month later, she was readmitted for pancreatitis. This time they found gallstones and sludge with a dilated biliary duct. So she did have high triglycerides, but the stones were thought to be the etiology. And shortly after that admission, she had a laparoscopic cholecystectomy. Nearly 2 years later, at age 23, she was admitted for the 4th time. Her triglycerides are over 2,000. In the absence of alcohol, a gallbladder, or any other causal medications, it was recognized that the triglycerides should be treated as the etiology. So using our dedicated treatment for this, she was kept NPO, she was given IV fluids and IV insulin. And by discharge, they restarted her on the fenofibrate. 1 month later, she was readmitted with an abnormal heart rate and found to have new AFib thought to be from pancreatitis. During that hospitalization, she also developed pancreatitis again. She was started on diltiazem. 2 months later, she was readmitted for the 6th time. This is starting to happen, as you can see, in more quick succession. She had been on Lovaza, and her inpatient doctors wanted her to be on Visipa instead, but insurance denied it. Since then, several other providers have attempted to do the same with insurance denial. So she stayed on Lovaza. Days after being discharged, she was readmitted again for high triglycerides. This time she was found to have subclinical hypothyroidism and started on levothyroxine. She was also started on a statin around this time. And now that brings us to where we are in April, when she is coming to establish with our clinic and is wondering what more can be done to keep her out of the hospital. So shown here is her past medical history, the most relevant of which we've already mentioned in her HPI and timeline. And we've already talked about her cholecystectomy, but she had a couple other surgeries as well. For her family history, so her mom has diabetes, her dad has hypertension, hyperlipidemia, and diabetes. Her maternal grandparents had diabetes, and her paternal grandparents had diabetes and hyperlipidemia, and her paternal grandmother had breast cancer. Her sister has bipolar disorder and a Chiari malformation. From her social history, she is married with 3 children. She's a stay-at-home mom with a high school education. She does not smoke, she no longer drinks, and she does not use any illicit drugs. I have mentioned most of her medications to this point, but just to recap, she is currently on fenofibrate, she's on Lovaza and rosuvastatin for her lipids. She is also on a PPI, sertraline, insulin, as we discussed, diltiazem, and levothyroxine. On exam, she is noted to be obese with a BMI of 40. Otherwise, she is well appearing. She does have some whitish striae on her abdomen, but she does not have any Cushingoid features. She is not noted to have any xanthomas or other skin findings. Here are the most recent CBC and BMP results, notable only for a mildly low sodium and a high glucose at 212. Additionally, her LFTs, her protein, albumin, and creatinine were all normal. Her TSH was 2 and A1C was 7.9. The most recent lipid panel was non-fasting, but did show a total cholesterol of 370, triglycerides just under 4,000, HDL of 12, and the LDL was unable to be calculated. Her direct LDL, when it was last measured, was 6 months ago, had been 29. So just to put her triglycerides in context, she has had several severely elevated triglycerides over the past 8 years, as you can see here. Most of the checks that we've had are over 1,000. These include both fasting and non-fasting values, hospital values, as well as clinic values. So there's a lot of variability in that itself, admittedly, but just to show you that this is a persistent and serious problem for our patient. Okay, so after the patient establishes with our endocrine clinic for the first time, our first visit focuses on first-line interventions for her elevated triglycerides. The very first cornerstone of management is dietary change, particularly noting that this patient's diet was unstructured. She skipped meals and snacked. Specifically from the ACC and the AHA, we know that we should be recommending a significant reduction in fat to less than 10 to 15% of one's daily calorie intake, and eliminating all refined carbs, which include any added sugars, sweeteners, white flour, white rice, or other processed foods. This patient is already abstinent of alcohol, but that is another important recommendation to pass along to our patients who struggle with severe hypertriglyceridemia. Since this is so key to the management of severe triglyceridemia, and also many patients struggle with dietary recommendations, I wanted to pause here to open it up on any comments on how best to counsel patients on these kind of changes.
Thank you, Michelle. We have a wonderful panel with us, and Dr. Leanne has also joined us. So our panel is going to start with Dr. Oscar Morey-Vargas. Dr. Vargas was the one who saw the patient, and I do have to say, considering he's obesity medicine certified, he was the perfect person to see the patient. So Dr. Vargas, I personally have also struggled with a lot of patients with the dietary recommendations. So in your experience, is there anything that really makes them stick to the diet? In this case, I would probably say that she might be genetically inclined towards hypertriglyceridemia considering her onset, but I still have been very unsuccessful with getting them to stick. You're muted, Dr. Vargas.
Can you hear me now?
Yes.
Okay, perfect. No, so absolutely, you're right. It is difficult for patients to follow a strict diet that should be very low in fat and also low in carbohydrates. I mean, it should be noticed that when we're dealing with mild or moderate hypertriglyceridemia, the focus is really to limit total calorie intake. And it's very important for those patients to limit carbohydrates, particularly simple processed carbohydrates. But when we're dealing with patients that have severe hypertriglyceridemia, particularly with a history of pancreatitis, then it is very important to have a diet that is severely limited really in fat. So we're talking about less than 40 grams, less than 20 grams of fat per day. Just to keep a perspective, we're talking about less than 4.5 teaspoons of olive oil per day. So this diet would be difficult to follow, for anybody really. And as you can imagine, for our patients that struggle with obesity, with diabetes, I mean, it becomes extremely hard. And for this patient in particular, I know that she struggled a lot. She struggled a lot. There was a particular incident when she was in the hospital where the nursing staff reported that there was some fat food, some McDonald's, burgers, pizza in the room. The patient stated that this was her husband's food, but anyway. So again, it's extremely difficult for patients to follow this diet, and we have to keep that in mind. But at the same time, we have to explain them clearly that diet is the cornerstone of management.
Is there any role of obesity medications in this, since you are the expert at this?
Certainly pharmacological therapy of obesity should be considered in this patient, because this patient has a history of diabetes. Then the first thing you think about is a GLP-1 receptor agonist, but she also has a history of pancreatitis, and this is considered a relative contraindication, although for many of us it's almost an absolute contraindication. So a GLP-1 receptor agonist would not be, I think, an ideal medication in her case. I mean, you could argue that you could try phentermine, glycemia, but also, in her case, there's a history of hypertension. Actually, I don't remember if this was mentioned by Michelle, but sometimes there was some anxiety background. So it really it became really challenging to find pharmacological therapy focusing on obesity management.
Thank you.
All right, so just to pick up, so we're talking about our first line intervention. So first line is dietary recommendations, but as also mentioned, so we need to be managing their comorbidities, which means improving glycemic control, focusing on weight loss, appropriate treatment of hypothyroidism, for example. These things can help lower the triglycerides as well. And then medications. So we have this patient on fibrates, an omega-3 fatty acid, and a statin. Recall that she had Visipa prescribed a couple times, but was turned down by insurance, and so is on Lavazza. So we'll talk about that more in a second here. But despite these primary interventions with dietary and sugar improvements, she was readmitted twice more in the 2 months following for routine blood work that showed she had high triglycerides over 4,000. The patient was so afraid of developing pancreatitis that she was admitted preventatively with IV insulin and IV fluids. So at this point in time, she's getting increasingly frustrated, and she wants to know what else can be done to help keep her out of the hospital. So I'd like to open it up to the group again. So what other treatments would you offer her to lower her triglycerides?
So we're going to move on to other people in our panel. We have Dr. Leanne Olansky, who's Emeritus Professor at University of Oklahoma and is considered somebody who knows everything about everything. Dr. Olansky.
Well, I think that usually I'm not someone who goes rapidly to gastric bypass surgery, but in this case, I think I would, because she has 3 big problems: severe obesity, type 2 diabetes, and hyperlipidemia, all of which should benefit from bariatric surgery. So I think I would try to do it as soon as possible while she still has some pancreas left.
Thank you. We also have Dr. Mario Skugor, who's the Director of Education for our institute. Dr. Skugor, what thoughts do you have regarding what can we do further in this
Yeah,
case?
I mean, first of all, I think we try to figure out her compliance over here. I mean, she's not, I mean, we are doing what, you know, our normal kind of guidelines are telling us to do, like recommend a very low fat diet. Problem with her, she is having diabetes too, is morbidly obese. So we're giving her a statin, I hope in a full dose. We're giving her fibrates, we're giving her omega-3 fatty acids. So she is, according to our guidelines, she's fully treated, but her triglycerides over 4,000. So one question is compliance with the diet, compliance with taking medications. Uh, Bariatric surgery would, I mean, in my opinion, if you have diabetes and you are morbidly obese, you would benefit from the bariatric surgery. And other than that, well, there is some experimental treatments that can be done, but I'm not sure if any of them FDA approved right now. I know that there is some kind, they're looking at a inhibit, you know, I can't remember what it was, but it was something about ApoC2 or 3, ApoC3, where was some kind of experimental medications. And I think if she is compliant and she cannot be treated, we should probably look to put her in some of clinical studies where they, you know, trying to figure out this new medications for the really high triglycerides. I mean, 4,000 with all this treatment, that is really high. Now, in terms of the treating that pancreatitis at this time, you can actually do plasmapheresis, you know, but that's again not long-term solution. That is a short-term solution. So what we want to do, we want to prevent the occurrence of this further pancreatitis. So that is not probably maybe feasible if she does it every so often. But you know, diet is extremely important here. I mean, if she has a triglycerides over 1,000, has chylomicrons, they're not clearing up. So, you know, she's keeping the like from one meal to another meal. So really, strict diet is the one of the important things.
The BMI of 40 tells you she's not limiting her diet. I mean,
Oh, yeah.
I mean, if she's got a BMI of 40 and she's maintaining that, and she's supposed to be limiting her fat and her carbs, you know, what is she eating? Just egg whites and a lot of them?
That's what I'm saying. I mean, your compliance is probably a problem here.
My question here is, if she is not compliant with the diet after multiple admissions for hypertriglyceridemia, the question is, would she be a good candidate for bariatric surgery? Because we have all seen lots of patients, status post gastric bypass, who are drinking their way back to weight gain.
That's
with
exactly what I'm pointing out.
soda or alcohol in a lot of cases.
Look into the compliance first, absolutely, because you know if she's not compliant with this, she's not going to be compliant with anything. I mean, what better stimulus for compliance you want than acute pancreatitis attack? My freaking God, yeah. So if she's not doing this, she's not going to do anything else. So let's go see.
I am also going to invite Dr. Carranza Leanne, who has joined us early. Dr. Leanne, what do you think of this case?
I agree with all my colleagues. Most of the patients that we see in clinic with hypertriglyceridemia, it's usually due to a secondary cause, either uncontrolled diabetes, medication-induced, alcohol. So addressing the secondary etiology is what we need to do. However, it seems that this patient, in addition to having a secondary cause for her high triglycerides, she has a genetic predisposition to high triglycerides. So usually you would address the secondary cause and that should fix it. And in this case, I guess it's more challenging because she has both. This is a rare patient that has both a secondary etiology plus it seems a genetic predisposition to having high triglycerides. And that I think makes it more challenging.
Thank you. Dr. Adi Mehta, you have a question or a comment?
I agree with all of the discussion, but I wonder if you could just get back to some of the physiology that drives why this triglyceride is going up. Agreed, she's got potentially a genetic predisposition, but the real physiology that drives triglycerides higher is the lack of an insulinization at the level of the liver. The lack of insulinization at the level of the liver is going to cause these free fatty acids to be released and repackaged. So this
Dr. Mehta,
she hasn't got enough insulin. Look at what we're doing. We're giving her 60 units of Lantus. It's a very good basal insulin. And we're giving her a piddly little dose of 5 units of Humalog. Now, if you look at what happens in physiology, triglycerides get accumulated overnight when you run out of insulin. But most importantly, they also get accumulated after every meal. Because if you don't have the first phase of insulin secretion, at that point in time, you are going to drive whatever you've got into triglycerides. So this lady needs an acutely acting insulin. I agree with Dr. Vargas when he says, with the question of pancreatitis, this will be a tough proposition. But the GLP-1 might very well reintroduce the first phase of insulin secretion in this lady. By that, you might actually limit, I'm not going to say take away her tendency to triglycerides, but you limit her ability to produce triglycerides. If you're not going to use that, you've got to give her a little more acute insulin with meals. Otherwise, you're not going to stop the start of the development of triglycerides. So in my opinion, if you're going to treat her and get away from the diet, because I agree with you, her chance of sticking to a diet and exercise program is as good as a snowball in hell. Okay, so I mean, quite honestly, I don't think that's going to work. We're going to have to take the responsibility to fix this. And I think we need to go back to physiology and say, where is the defect that we can actually attack? And so that's my contribution.
Let me tell you, I don't think there's one thing that is going to work here. So we are talking, what are we going to focus on? But absolutely. I mean, she's diagnosed at age 10 before she had diabetes. So I would bet my arm that she has genetic issue with, lipoprotein lipase or one of these cofactors that actually allow for lipolysis. Why, if your triglycerides are below 1,000, yes, the most contribution goes from the synthesis from the liver. Once you get over 1,000, it's really clearing up the dietary fat. That's why the recommendation is that if you have below 1,000 or below 800, I can't remember, there is actually diet should focus on a weight reduction and so on. Once you get over 1,000, you really limit the fat intake. Now, she developed diabetes. She has 7 bouts of pancreatitis. We don't know what her insulin reserve is. So I agree. We should use every one of these mechanisms we can. So I agree with Dr. Mehta too. We have to cover her with insulin properly, maybe give her GLP-1 too. But GLP-1 also can cause issues with the pancreatitis. So we have to be very careful with that. But the compliance with the diet, understanding why is this important, from the patient standpoint, I think is the most important part. If she knows why we are doing it and why we're doing different steps in her treatment, she might be more willing to stick to it. So education, and being friendly, not being judgmental, asking about like all the details of the lifestyle, that would be too. But again, I believe she has genetic cause, and one of these new experimental medication might be good for her.
Dr. Morey-Vargas.
Yes, so just a couple of comments. So first of all, well, I certainly agree that her initial MDI insulin program, before we saw her, was really not appropriate, and obviously there was too much basal there and not enough prandial insulin. So that was her insulin program before we saw her. After we started following the patient, that insulin program was modified completely, and in fact, more recently, she actually has. If you look at the proportion of prandial insulin on her current program, it's actually larger than basal insulin. So we were working with her very closely to optimize her insulin treatment, and in fact, her glucose levels improved significantly in the following weeks and months. So that's one thing. The other thing to consider is that if we are actually thinking of a genetic condition.
Oops. Oscar, you muted. Oscar, you muted. We lost you.
Yeah, it's muting automatically here.
Yes.
But yes, anyway. So what I was saying is that if we're considering a genetic cause here, so sometimes the main problem could be lipoprotein lipase, right? So a problem there, not so much with the excessive production of LDL related to insulin deficiency. So that's, and she probably has both. I most likely she has both, but those are things to consider.
Could I make a suggestion?
Yes.
Why don't you try a U500 with each meal?
So
if you try the U500, you'll get a very high level of insulin with the meal, and you might find that that might inhibit. I'm not going to take away a genetic tendency, but I want to see if we can inhibit the secondary tendency to make triglycerides.
So to clarify, Dr. Maida, Michelle did mention she's actually 5 to 40 units before each meal right now. And considering we have talked a lot about her non-compliance, I would think that her diet, her meal sizes are so varied that it will even be difficult to put her on a standard dose of U500, and also difficult to give her parameters on how to adjust it based on her diet. So I think the insulin suggestions are wonderful, but I do think that the practicality of doing it in somebody who's non-compliant is much harder. But
her chances of having a low blood sugar are not very good. She is severely insulin resistant.
No, I agree with that. I think the chances of her injecting herself before each meal is going to be the harder part. But Michelle, please go on. We have a few more slides before we finish.
Yes, thank you for that discussion. We had many of the same thoughts come up, and so I'm going to briefly touch on some of those points. And because of time, I'm going to fly through kind of quick here. So one of the first questions we had is, does it really matter the Lovaza versus the Vascepa in terms of like what evidence is there for hypertriglyceridemia and pancreatitis? And as you can see from this figure here, Lovaza and Vascepa are different substances. So it's not surprising that from a meta-analysis, there is a slightly different effect on your triglycerides based on these two medicines. So Lovaza is on top, Vascepa on the bottom. Lovaza actually has more triglyceride lowering effect in this analysis, but it had a negative effect of increasing your LDL. It also did have a positive HDL effect. So I would be remiss if I didn't also mention the Reducit and the Strength trials, which showed us that there was cardiovascular benefit from Vascepa, but not Lovaza, and that's why that's often our omega-3 medicine of choice. But it does come at a cost. For this patient to get it out of pocket, it would be about $300 a month. So that's one of the reasons why this patient has not been on Vascepa. Another thing that came up in our discussion was talking about the PCSK9 inhibitors, and if there's a role, because we know that there's some modest reduction in triglycerides that has been reported in several patients with high triglycerides. So this is in patients who had high triglycerides, but not severely high. So between 200 and 500 triglyceride levels, we saw that triglycerides were lowered somewhere between 12% and 30% in a couple of these studies. Other studies did not reach statistical significance. Granted, this is not in patients like ours with very, very high triglycerides over 1,000. So there's a potential for benefit in that population that hasn't been studied. A lot of people have spoken about bariatric surgery, and I think that's a really good recommendation given this patient's comorbidities as well. And so I wanted to share a very small study done in Taiwan in 2015, looking at patients with severe triglyceridemia over 1,000 at baseline. They got bariatric surgery, either bypass or restrictive type. This is 14 men and 6 women, average 35 years old with a BMI of 38. Their average pre-op triglyceride level was 1,700, and 4 of them had recurrent pancreatitis, 13 with diabetes. After bariatric surgery, they had a mean lowering to 200 in their triglycerides, and at a year, just under 200. So this is pretty impressive triglyceride lowering. It was associated with a 25% weight loss, and there was only 1 case of perioperative pancreatitis in the 6 months surrounding surgery. And in 6 months to 13 years in follow-up, there were no cases of pancreatitis in this patient population. Granted, there's a lot to critique about this study. Obviously, it's very small, and it does not distinguish between the types of bariatric surgery, which we could discuss more further. If people are interested, I have a reference here as well that refers to the different types of bariatric surgery. But overall, it seems like bariatric surgery is very helpful for these patients if it's indicated. And in fact, our patient did opt for bariatric evaluation and got a laparoscopic sleeve gastrectomy 2 weeks ago now. So we'll see how that affects her triglycerides. But meanwhile, we did send our patient to genetics because she had some genetic history with her dad and her paternal grandparents with elevated cholesterol. So there was suspicion for a genetic cause, namely familial chylomicronemia syndrome, or FCS, which causes severely elevated triglycerides and recurrent pancreatitis. From our geneticists, we know that 2 out of 3 people with FCS have 2 identifiable genetic changes that are present and interfere with our body's lipid recycling system. So our genetic test here looks for 36 genes for variants, specifically LPL, ApoA5, ApoC2, and so on, to look for these variants. So usually it's an autosomal recessive, so each pathologic gene, one is inherited from each parent. So not necessarily, it doesn't preclude our patient having it if her parents are not themselves affected because of the autosomal recessive inheritance pattern. So for our patient, she did have a heterozygous pathologic variant of the LPL gene. Specifically, this is a null variant, which is associated with more significant hypertriglyceridemia. And this is just a quick copy of her report. From this, we can take away that she does have a genetic tie for her elevated triglycerides, but this does not confirm the FCS syndrome because she only had 1 genetic mutation. So I'm just going to stop there because I know that we have our talk coming up here with our guest speaker. So thank you, everybody, for contributing to our discussion. And I hope that I was able to provide some answers from our literature review and move forward with how best to manage our patient and prevent her pancreatitis in the future.
Thank you so much, Michelle. A couple of comments from the chat. Dr. Kashyap mentions that processed foods contain trans fat, so it's also important to eliminate. And we have a question about niacin, which I'm sorry, Dr. Borgen, we are going to skip for now. And we are going to move on to our guest speaker. Dr. Leanne, do you want to go ahead and share your presentation? And we're going to stop sharing from here.